Let's focus on high-yield clinical cases related to coronary artery disease. Coronary artery disease, CAD, is commonly caused by atherosclerosis, leading to reduced blood supply to the myocardium and resulting in a mismatch between myocardial oxygen supply and demand. What is the cardinal symptom of CAD? Acute retrosternal chest pain is the cardinal symptom of coronary artery disease. Other symptoms to think about also include shortness of breath, nausea, anxiety, and dizziness. How are chest pain syndromes categorized? In keeping with the new chest pain guideline, chest pain syndromes are categorized using the terms cardiac, possible cardiac, and non-cardiac, no longer recommended using the following terms, such as typical angina, atypical angina, and non-anginal chest pain. Here's a 42-year-old male with a 4-month history of intermittent chest discomfort. He describes the pain as a brief, sharp sensation that occurs sporadically and is not related to physical activity or rest. Each episode lasts a few minutes and is occasionally associated with mild anxiety, but no other symptoms, such as shortness of breath, dizziness, or palpitations. He has no significant medical history, leads a healthy lifestyle, and does not smoke, drink alcohol, or use illicit drugs. His vitals are all within normal limits, and a physical examination, including cardiopulmonary evaluation, is unremarkable. An ECG performed in the office shows a normal sinus rhythm with no abnormalities. Given this clinical scenario, what is the most appropriate next step in managing this patient's chest pain? A. Exercise treadmill test. B. Stress echocardiography. C. Coronary angiography. D. Reassurance and no further testing. Or E. 24-hour Holter monitor. This patient presents with chest pain that is not associated with exertion and lacks other concerning features of coronary artery disease. His normal physical exam, ECG, and low-risk lifestyle further reduce the likelihood of CAD. Given the low pretest probability of CAD, further testing, such as stress tests or coronary angiography, is not warranted. Reassurance and no further testing are appropriate in this case. The focus should be on educating the patient about the low risk of serious heart disease and managing any anxiety that may be contributing to his symptoms. Further testing would be unnecessary and could lead to unwarranted anxiety and potential harm from false positives. 50-year-old male is here for a routine checkup. He is asymptomatic but concerned about his risk for heart disease, as his father had an MI at the age of 52. The patient has a history of hypertension, well controlled with lisinopril, and hyperlipidemia, for which he takes atorvastatin. He does not smoke and exercises regularly. His recent blood work shows a total cholesterol of 210, LDL 130, and HDL 45. His blood pressure is 125/80, and his BMI is 26.5. A PE finding is unremarkable, and he is concerned about his risk for coronary artery disease and asks if there are any additional tests he should undergo to assess his cardiovascular risk. Which of the following is the most appropriate next step in evaluating this patient's risk for CAD? A. Exercise treadmill stress test. B. Coronary artery calcium scoring. C. Coronary angiography. D. Echocardiography. Or E. Holter monitoring. The correct answer is B. Coronary artery calcium scoring. Coronary artery calcium scoring is a non-invasive imaging technique that quantifies the amount of calcified plaque in the coronary arteries. It is particularly useful for risk stratification in patients who are asymptomatic with an intermediate risk of atherosclerotic cardiovascular disease, like this patient who has several risk factors, including a family history of premature coronary artery disease, hypertension, and hyperlipidemia. A coronary artery calcium score provides additional information about the burden of subclinical coronary atherosclerosis and can help guide decisions about the intensity of preventive strategies such as statin therapy. In this case, CAC scoring would help assess the extent of coronary artery disease and provide more precise risk stratification. Other options, such as an exercise treadmill stress test or a coronary angiography, are typically used in symptomatic patients or those with a higher pretest probability of CAD. Echocardiography and Holter monitoring are not indicated for asymptomatic patients without specific symptoms suggestive of structural heart disease or arrhythmias. CAC scoring is the most appropriate next step in this context, as it can help refine the patient's cardiovascular risk and guide management decisions. 48-year-old female presents with a 6-month history of intermittent chest pain. She describes the pain as a mild squeezing sensation in the middle of her chest, occurring both at rest and during physical activity. The episodes typically last 10 to 15 minutes and are not relieved by rest. She has a history of hypertension and is on lisinopril. Her lipid levels are borderline, and she has a family history of CAD, with her father having an MI at the age of 55. She doesn't smoke or drink alcohol. Her blood pressure today is 128 over 82, and her BMI is 27. A resting ECG is normal. Given her age and symptoms, her pretest probability of CAD is considered intermediate. Which of the following is the most appropriate next step in evaluating her chest pain? A. Exercise treadmill stress test. B. Coronary angiography. C. Coronary CT angiography. D. Myocardial perfusion imaging. Or E. Echocardiography. The correct answer is C. Coronary CT angiography. Coronary CT angiography is a non-invasive imaging technique that provides detailed images of the coronary arteries. It is particularly useful for evaluating patients with an intermediate pretest probability of coronary artery disease and is the preferred technique in patients who is 65 years old and younger. 65-year-old male presents with a 2-month history of intermittent chest discomfort. He describes the pain as a dull ache on the left chest, which occurs during emotionally charged situations, such as arguments with family members. The episodes last for about 5 to 10 minutes and resolve spontaneously. His medical history includes hypertension, for which he takes lisinopril. He leads an active lifestyle, walking daily, and follows a healthy diet, but he smokes. The cardiac examination reveals a PMI in the fifth intercostal space at the mid-clavicular line, with no murmurs, rubs, or gallops. A resting ECG shows normal sinus rhythm with no ischemic changes. Given this presentation, which of the following is the most appropriate next step to evaluate for coronary artery disease in this patient? A. Coronary angiography. B. Echocardiography. C. Treadmill exercise stress test. D. Halter monitoring. Or E. Reassurance and lifestyle modification. The correct answer is C. Treadmill exercise stress test. This patient presents with symptoms suggested of stable angina, particularly given that his chest pain is triggered by emotional stress and resolves with rest. While his physical examination and resting ECG are normal, these findings do not exclude the possibility of CAD, especially considering his risk factors, including hypertension and smoking. The most appropriate next step in evaluating for CAD in this patient is a treadmill exercise stress test. This non-invasive test evaluates the heart's response to physical stress, which can unmask ischemia not detected at rest. If the stress test is positive, it would indicate myocardial ischemia and the need for further evaluation. potentially leading to interventions such as coronary angiography or medical management adjustments. Other options, such as coronary angiography, are invasive and usually reserved for patients with high risk features or positive findings on non invasive testing. Echocardiography and Holter monitoring have their roles, but are not first line tests for evaluating exertional chest pain. A 65-year-old female presents to her primary care physician with a 4-month history of chest discomfort. She describes the discomfort as a pressure like sensation that occurs when she is walking briskly or climbing stairs. The pain is located in the center of her chest and sometimes radiates to her neck. It usually subsides within 5 minutes after she rests. She has a history of hypertension and hyperlipidemia, for which she takes lisinopril and atorvastatin. She does not smoke or drink alcohol. Her blood pressure is 130 over 80 and her pulse is 78 beats per minute. Physical examination, including a cardiopulmonary exam, is unremarkable. A resting ECG shows normal sinus rhythm with no ischemic changes. What is the most appropriate next step in evaluating this patient's chest pain? A. Coronary angiography test. B. Pharmacological stress test. C. Treadmill stress electrocardiography. D. Echocardiography. Or E. Holter monitoring. And the correct answer is C. Treadmill stress electrocardiography. This patient presents with symptoms consistent with stable angina, including exertional chest pain that resolves with rest. Given her history of hypertension and hyperlipidemia, she is at increased risk for CAD. The most appropriate next step in evaluating her chest pain is treadmill stress ECG, also known as treadmill stress test or exercise stress test. Treadmill stress ECG involves exercising on a treadmill while the patient's ECG is continuously monitored for signs of ischemia, such as ST segment depression. This test is particularly useful for evaluating patients with an intermediate pretest mobility of CAD who are able to exercise and have a normal resting ECG. Coronary angiography is more invasive and typically reserved for patients with high risk features or those with significant ischemia detected on non invasive testing. A pharmacological stress test is used for patients who are unable to exercise. Echocardiography and Holter monitoring are less useful in this context for evaluating exertional chest pain suggested of coronary artery disease. A 62-year-old man presents with a 2-month history of chest discomfort that occurs when he is walking up a hill near his home or when he carries groceries up a flight of stairs. The discomfort is described as a mild pressure in the center of his chest and usually subsides within a few minutes of rest. Denies shortness of breath, palpitations, or dizziness. His medical history includes his hypertension, type 2 diabetes, and hyperlipidemia. His current medications include metoprolol, lisinopril, atorvastatin, and metformin. He drinks 2 to 3 cups of coffee per day and does not smoke or consume alcohol. His pulse is 72 beats per minute, respirations are 20 breaths per minute, and blood pressure is 138 over 85. Physical examination is unremarkable. A resting ECG shows a normal sinus rhythm and a recent blood work is within normal limits. He is scheduled for a treadmill exercise stress test in 3 days. Which of the following medications is the most appropriate to discontinue before the procedure? A. Metoprolol. B. Atorvastatin. C. Lisinopril. D. Metformin. E. Aspirin. The correct answer is A, metoprolol. Metoprolol, a beta blocker, should be discontinued before a treadmill exercise stress test because it can blunt the heart rate response to exercise, potentially leading to a false negative results. The purpose of a stress test is to assess the heart's ability to respond to increased demands, and beta blockers can mask symptoms of ischemia by limiting the increase in heart rate and blood pressure that typically occurs with exercise. Patients are usually advised to stop taking beta blockers 24 to 48 hours before the test, depending on the prescribing physician's instructions. Other medications such as atorvastatin, lisinopril, metformin, and aspirin do not typically interfere with the results of a stress test and can be continued. A 62-year-old man with a 4-month history of intermittent chest discomfort to which he describes the pain as a dull, pressure-like sensation that occurs primarily when he is physically active or exposed to cold weather. The episodes typically last for several minutes and are relieved by rest. He has a history of hypertension, type 2 diabetes, and peripheral arterial disease. He underwent a right above knee amputation due to complications from diabetes 2 years ago. His physical activity is limited due to his amputation and he uses a wheelchair for mobility. He takes lisinopril, metformin, and aspirin. He does not smoke or consume alcohol. On exam, his pulse is 82, respirations 18, with a blood pressure of 142 over 85. An ECG shows normal sinus rhythm with no ischemic changes. Which of the following is the most appropriate next step in diagnosing his condition? A. Treadmill exercise stress test. B. Pharmacological cardiac stress test. C. Coronary angiography. D. Echocardiogram. Or E. Ambulatory ECG monitoring. The correct answer is B. Pharmacological cardiac stress test. This patient presents with symptoms suggested of stable angina, likely due to underlying coronary artery disease. Given his history of hypertension, diabetes, and limited mobility due to an above knee amputation, a standard treadmill exercise stress test would not be feasible. In such cases, a pharmacological cardiac stress test is the most appropriate diagnostic tool. This test uses medications such as adenosine or dobutamine to simulate the effects of exercise on the heart. It can help identify areas of ischemia. Pharmacological stress test is particularly useful for patients who are unable to perform adequate physical exercise due to mobility limitations. Coronary angiography is more invasive and typically reserved for cases where non-invasive tests suggest significant ischemia. An echocardiogram or an ambulatory ECG monitoring would not be the best initial diagnostic test in this scenario as they are less specific for diagnosing ischemia related to coronary artery disease. A 68-year-old man with a history of hypertension, hyperlipidemia, and a previous coronary artery bypass graft surgery presents to the cardiology clinic for evaluation of worsening exertional chest pain over the past 4 months. His chest pain typically occurs during physical activity and is relieved by rest. The cardiologist offers a pharmacologic stress test using adenosine to assess myocardial perfusion. During the test, the patient develops chest discomfort similar to his usual symptoms, and the ECG shows new ST segment depression in the lateral leads. Which of the following is the most likely underlying mechanism of this patient's signs and symptoms during the procedure? A. Increased myocardial oxygen demand. B. Microvascular spasm. C. Coronary artery dissection. D. Dilation of coronary vasculature associated with coronary steal syndrome. Or E. Aortic stenosis. The correct answer is D. Dilation of the coronary vasculature associated with coronary steal syndrome. This patient's symptoms and ECG changes during the adenosine stress test are indicative of coronary steal syndrome. Coronary steal syndrome occurs when there is a dilation of the coronary vasculature in non-obstructive arteries, leading to a diversion of blood flow or steal away from areas supplied by significantly stenosed or occluded vessels. Adenosine and other vasodilators such as dipyridamole cause dilation of healthy coronary arteries, which can paradoxically reduce blood flow to the ischemic regions of the myocardium. exacerbating ischemia in those areas. This mechanism explains the reproduction of the patient's symptoms and the ECG changes during the test. Coronary steal syndrome is particularly relevant in patients with prior coronary interventions or significant coronary artery disease where collateral circulation may be present. Just a reminder, both cardiac stress testing and coronary CT angiography are effective tools for risk stratification in patients with an intermediate to high pretest probability of obstructive coronary artery disease. A 58-year-old man presents with a 6-month history of chest pain that occurs during exertion, such as walking up a flight of stairs. The pain is described as a pressure-like sensation in the center of his chest that radiates to his left arm and jaw. It typically lasts for about 5 to 10 minutes and is relieved by rest or sublingual nitroglycerin. He has a history of hypertension, hyperlipidemia, and type 2 diabetes, for which he takes lisinopril, atorvastatin, and metformin. He is a former smoker with a 30-pack year history but quit 10 years ago. A recent exercise treadmill showed a 2 mm ST segment depression in the lateral leads after 5 minutes of exercise, which resolved with rest. His blood pressure is 135/80 and pulse is 75. Given the patient's symptoms and stress test results, which of the following is the most appropriate next step in management? A. Increase the dose of lisinopril. B. Add a beta blocker to his regimen. C. Refer for cardiac catheterization. D. Initiate long-acting nitrate therapy. Or E. Repeat the stress test in 6 months. The correct answer is C. Refer for cardiac catheterization. This patient presents with stable angina, characterized by chest pain during exertion that is relieved by rest. His history of hypertension, hyperlipidemia, diabetes, and significant smoking history places him at high risk for coronary artery disease. The recent exercise treadmill test showing ST segment depression suggests inducible ischemia, indicating that there is a significant likelihood of obstructive coronary artery disease. Cardiac catheterization, also known as coronary angiography, is the most appropriate next step in this patient's management. It allows direct visualization of the coronary arteries and helps determine the severity and extent of any blockages. This is crucial in deciding whether the patient might benefit from revascularization, such as PCI or CABG. A 58-year-old female presents to her primary care physician with a 3-month history of chest discomfort that occurs during physical activity such as brisk walking or carrying groceries. She describes the pain as a squeezing sensation in the center of her chest that lasts for several minutes and is relieved by rest. She has a history of hypertension and hyperlipidemia, which are well controlled with lisinopril and atorvastatin. She has never smoked and does not have diabetes. Her blood pressure is 130/78 and her pulse is 72. On physical examination and ECG performed in the office are unremarkable. In addition to lifestyle modifications and continuing her current medications, which of the following is the most appropriate next step in prevention of recurrence or progression of CAD? A. Clopidogrel. B. Warfarin. C. Aspirin. D. Statin. Or E. Beta blocker. The correct answer is C. Aspirin. Aspirin is a cornerstone of treatment for stable angina as it reduces the risk of MI and other cardiovascular events by inhibiting platelet aggregation. In patients with stable CAD, Aspirin is recommended to decrease the likelihood of thrombus formation in coronary arteries, thereby lowering the risk of acute coronary events. This patient presents with symptoms suggested of stable angina and has risk factors such as hypertension and hyperlipidemia. Adding aspirin to her treatment regimen is crucial for secondary prevention of cardiovascular events. Clopidogrel is an alternative for patients who cannot tolerate aspirin or have a contraindication, but it is not first line in this scenario. Warfarin is not indicated for stable angina. The patient is already on a statin, which is appropriate for lipid management and cardiovascular risk reduction, and beta blocker could be added to manage symptoms, but in this question, aspirin is the key next step for reducing her overall cardiovascular risk. A 62-year-old man presents to his primary care physician with a 4-month history of chest pain that occurs during physical activity such as walking uphill or climbing stairs. He describes the pain as a pressure-like sensation in the middle of his chest that radiates to his left arm and usually lasts for 5 to 10 minutes. The pain is relieved by rest. He has a history of hypertension and hyperlipidemia, for which he takes lisinopril and atorvastatin. He is a former smoker with a 30-pack years history and quit smoking 5 years ago. His blood pressure is 135 over 80, pulse 80, and physical examination unremarkable. A resting ECG shows normal sinus rhythm with no ischemic changes. What is the most appropriate next step in managing this patient's symptoms? A. Long-acting nitrate. B. CCB. C. Beta blocker. D. Aspirin. Or E. ACE inhibitor. The correct answer is C. Beta blocker. This patient presents with symptoms consistent with stable angina, characterized by exertional chest pain that is relieved by rest. Beta blockers are the first line treatment for stable angina as they reduce myocardial oxygen demand by lowering heart rate, blood pressure, and contractility. This helps prevent anginal episodes during physical exertion. Beta blockers have been shown to improve symptoms and reduce frequency of angina in patients with stable CAD. They are particularly beneficial in patients with a history of hypertension, as in this case, while long-acting nitrates and CCBs can also be used to manage angina. They are typically considered when beta blockers are contraindicated or ineffective. Aspirin is important for reducing the risk of cardiovascular events, but does not directly address anginal symptoms. An ACE inhibitor, like lisinopril, is appropriate for blood pressure control and reducing cardiovascular risk, but is not first line for symptom control in angina. In this patient, starting a beta blocker is the most appropriate next step to manage his stable anginal symptoms. Fact: of all the anti-anginal medications, beta blockers are used to reduce the risk of MI and death, as well as to provide chest pain relief in patients with coronary artery disease. If a patient with stable angina continues to experience chest pain despite being on a beta blocker, add a dihydropyridine calcium channel blocker or nitrate to the treatment regimen. A 65-year-old man with a history of chronic stable angina, hypertension, and hyperlipidemia presents to the clinic for a follow-up visit. Despite being on maximal doses of a beta blocker, CCB, and a long-acting nitrate, he continues to experience episodes of chest pain with exertion. These episodes occur 2 to 3 times per week and are relieved with some sublingual nitroglycerin. His blood pressure is well controlled and his heart rate is within target range. An ECG performed during a recent exercise stress test showed no new changes, and a coronary angiogram conducted last year revealed significant but stable atherosclerotic disease. He is compliant with his medication and lifestyle modifications, including smoking cessation. Which of the following is the most appropriate addition to his current therapy to help reduce the frequency of his anginal episodes? A. Digoxin, B. Ivabradine, C. Ranolazine, D. Spironolactone, or E. ACE inhibitor. The correct answer is C, ranolazine. Ranolazine is an anti-anginal medication that can be added to the treatment regimen of patients with chronic stable angina who remain symptomatic despite optimal therapy with other anti-anginal agents such as beta blockers, CCB, and nitrates. Ranolazine works by inhibiting the late sodium current in the myocardial cells, reducing intracellular calcium overload and thus decreasing myocardial oxygen consumption without significantly affecting heart rate or blood pressure. This makes it particularly useful in patients who are already on optimal doses of other medication but continues to have angina. It is not typically used as first-line therapy, but is effective as an add-on in refractory anginal cases. A 59-year-old male with a 3-month history of exertional chest pain, to which he describes the pain as a pressure-like sensation in the middle of his chest that occurs during moderate physical activity, such as brisk walking or climbing stairs, and is relieved by rest. He has a history of hypertension, hyperlipidemia, and a family history of coronary artery disease. His current medications include lisinopril, atorvastatin, and aspirin. A recent exercise stress test revealed an ST segment depression in the anterior leads, suggesting inducible ischemia. Coronary angiography was then performed, and it revealed a 50% stenosis of the left main coronary artery. The patient has been on optimal medical therapy, including a beta blocker, but continues to experience symptoms. What is the most appropriate next step in managing this patient's condition? A. Continue current medical therapy. B. Cabbage. C. PCI. D. Increase the dose of beta blocker. Or E. Start a calcium channel blocker. The correct answer is C. Percutaneous coronary intervention PCI with stenting. This patient presents with stable coronary artery disease, complicated by the significant stenosis in both the left main coronary artery and the left anterior descending artery. A 50% stenosis of the LMCA is particularly concerning because the LMCA supplies a large portion of the heart, including the LAD and the left circumflex artery. A significant stenosis in the LMCA can lead to extensive MI, increasing the risk of major adverse cardiovascular events. Percutaneous coronary intervention, PCI, with stenting is an appropriate and effective treatment option for patients with LMCA stenosis, particularly when the stenosis is about moderate 50% and involves additional significant lesions such as proximal LAD. PCI offers a less invasive alternative to CABG and can provide excellent outcomes for revascularization in patients with anatomically favorable lesions. CABG may be considered in cases of more severe LMCA stenosis of at least 70% obstruction or when there is a complex multi-vessel disease. However, in this patient with a 50% LMCA stenosis and a significant LAD involvement, PCI is a suitable choice for revascularization as it can effectively alleviate symptoms and reduce the risk of adverse outcomes. Simply continuing medical therapy, increasing the dose of a beta blocker, or adding a CCB would not adequately address the significant coronary stenosis and the associated risk of ischemic events. Revascularization with PCI is necessary to provide symptomatic relief and reduce the risk of myocardial infarction or even death. A 68-year-old man with a 9-month history of exertional chest pain, to which he describes the pain as a heavy pressure in the center of his chest that radiates to his left arm and occurs during activities such as walking or climbing stairs. The pain typically subsides with rest and has recently become more frequent, even occurring at rest on occasion. His medical history involves hypertension, type 2 diabetes, and hyperlipidemia. He is a former smoker with a 40-pack year smoking history. A recent exercise stress test was positive for significant ischemia, and coronary angiography revealed triple vessel disease, including 90% stenosis of the LAD, 80% stenosis of the left circumflex, and 70% stenosis of the RCA. Despite optimal medical therapy, including beta blocker, aspirin, and nitrate, his symptoms persist. What is the most appropriate next step in managing this patient's condition? A. PCI with stenting. B. Cabbage. C. Increase the dose of beta blocker. Or D. Start calcium channel blocker. The correct answer is B. Cabbage. This patient presents with stable CAD complicated by triple vessel disease involving the left anterior descending, left circumflex, and right coronary artery. The severity of his coronary lesions, particularly the involvement of the LAD and the persistence of symptoms despite optimal medical therapy, make him a candidate for revascularization. Coronary artery bypass grafting, CABG, is the most appropriate revascularization strategy for patients with multi-vessel disease, especially when the LAD is significantly involved. CABG has been shown to improve survival, reduce the risk of MI, and provide better long-term symptom relief compared to PCI in patients with complex multi-vessel CAD. While PCI may be appropriate for certain patients with less extensive disease, CABG is generally preferred in cases like this one, where there is a significant multi-vessel involvement, particularly when the LAD is affected. Simply increasing the dose of a beta blocker, starting a CCB, or continuing current medical therapy would not be sufficient to address the underlying severe coronary artery blockages and the patient's high risk of adverse cardiovascular events. CABG is necessary to achieve optimal revascularization and improve long-term outcomes. A 62-year-old female with stable angina presents for a 4-month history of increasing shortness of breath during physical activity, which improves with rest. She has a history of hypertension and hyperlipidemia. Her current medications include aspirin, metoprolol, and nitroglycerin. An echocardiogram reveals regional wall motion abnormalities in the inferior and lateral walls of the left ventricle. Cardiac catheterization reveals a 90% occlusion of RCA. The patient undergoes PCI with stent placement. After the procedure, her symptoms resolved. A follow-up echocardiogram 1 week later shows normal regional wall motion. Which of the following best explains the changes observed on the echocardiogram? A. Myocardial infarction. B. Coronary artery spasm. C. Myocardial stunning. D. Hibernating myocardium. Or E. Ventricular aneurysm. The correct answer is D. Hibernating myocardium. The patient's initial echocardiogram showing a regional wall motion abnormalities coupled with significant coronary artery stenosis suggests hibernating myocardium. Hibernating myocardium refers to areas of the heart muscle that have reduced contractile function due to chronic ischemia but have not yet undergone irreversible damage. After revascularization, such as angioplasty and stent placement, blood flow is restored, leading to the recovery of normal contractile function as observed in the follow-up echocardiogram. This reversible improvement distinguishes hibernating myocardium from myocardial infarction, where tissue damage is typically irreversible. A 58-year-old female with hypertension and diabetes presents to the ED 40 minutes after experiencing sudden onset of severe chest pain while watching TV. She mentions that earlier in the day she had a glass of wine to relax after dealing with a stressful situation at work. Her current medications include metformin and lisinopril. She has never smoked. On arrival, her heart rate is 98, blood pressure 140 over 90. The physical examinations are remarkable, with normal heart sounds and no signs of heart failure. An ECG taken on arrival shows ST segment elevations in the inferior leads. However, the chest pain subsides within 20 minutes, and a repeat ECG shows no abnormalities. Cardiac enzymes are within normal limits. Which of the following is the most likely underlying mechanism of this patient's chest pain? A. Coronary artery vasospasm. B. Acute coronary syndrome. C. Pericarditis. Or D. Aortic dissection. The correct answer is A. Coronary artery vasospasm. Patients with typical chest pain, normal troponin levels, and reversible ST segment elevations on ECG are likely experiencing vasospastic angina, also known as Prinzmetal angina. Common triggers for vasospastic episodes include triptans, alcohol, cocaine, and hyperventilation. 50-year-old male presents to the emergency department 20 minutes after experiencing sudden onset chest pain radiating to his jaw. The pain began while he was resting after taking sumatriptan for migraine headaches. He reports that similar episodes of chest pain have occurred in the past, typically resolving within a few minutes. He has a 25-year history of smoking, 1 pack of cigarettes per day. On arrival, an ECG shows a transient ST segment elevation in the inferior leads, but these changes normalize within 30 minutes. Serial serum troponins are negative. Which of the following is the most likely to prevent further episodes of chest pain in this patient? A. Beta blockers. B. Nitroglycerin. C. Statin. D. CCB. Or E. Aspirin. The correct answer is D. Calcium channel blockers. This patient likely has vasospastic angina, also called Prinzmetal angina, which is characterized by the transient episodes of chest pain at rest, often associated with ST segment elevations on ECG that resolve without causing permanent myocardial damage, as indicated by the negative troponin levels. Vasospastic angina is typically triggered by factors such as smoking and medications like sumatriptan, which can induce coronary artery vasospasms. Calcium channel blockers such as verapamil or diltiazem are effective in preventing these episodes by reducing coronary artery spasms. Thank you, and this ends my discussion on common clinical questions related to coronary artery disease.